Healthcare is changing, and Dr. Nancy RN is here for you. The topics are many, but each program stands on its own with 3 key action points for you to learn. Your guide to a healthier you in a changing world. Dr. Nancy RN.
Welcome to Dr. Nancy RN. I'm Nancy Valentine, PhD and registered nurse, and this show is dedicated to you, the consumer. My hope is that through our discussions with experts through the community and across the nation, that we will have an opportunity to give you more information in order for you to manage your health. And if you manage your health successfully, this will help you, your family, and community. And hence we'll have a happier and healthier nation and world. The idea that we are going to tackle today is we're going to talk about planning your life with the end in mind. Advanced Care Planning, ACP as it is referred to. Now, why do we want to talk about this? People typically do not think of the end of their lives while they are busy living life. For most of us, living life is challenging enough. Not until faced with a threatening illness personally or within one's family or friendship circles do we stop long enough, and even then we don't stop necessarily, to take the time to thoughtfully consider how would we want to maintain control and exit our lives with grace and dignity? And the real challenge is, how do we orchestrate what we want and know with certainty that our wishes will be honored when the time comes? Today we have a guest, Dr. Carl Allsweet, who has tackled these questions and has developed a meaningful process to assist individuals and families in making such choices and how to preserve their quality of life long before an illness or accident has occurred. Dr. Carl Allsweet is both a maverick and a trailblazer in the field of palliative care and end of life. And let me tell you a little bit about him. He is the palliative care director at Bryn Mawr Hospital and the owner of Dr. Carl Allsweet Advanced Care Planning. He is the first physician in the United States specializing in advanced care planning. And he also serves in his role at Lankenau Hospital as chair of the Bioethics Committee and is an active member of the Mainline Health System Bioethics Committee. Prior to practicing palliative care, Dr. Allsweet was a surgeon, and it was through his work as a surgeon that he saw some of the gaps in care and moved mid-career into really serving in a palliative care capacity. And what his practice of palliative medicine does is it brings relief to patients and their families through goal-oriented conversations, education, and expert pain and symptom management. Through his private practice, Dr. Allsweet ensures patients' values regarding end of life are honored and by providing professional guidance and expertise relevant to the patient's individual situation. He was also the first surgeon to be given certification for hospice and palliative care by the American Board of Surgery in 2009. Now, I know that Dr. Allsweet is an expert because we worked together at Mainline Health, and it was really a very positive experience because Carl is a person who commands respect. Not only is a physician who is really expert in his field and very knowledgeable, but because he's a real team player and he honors the work of other team members and really brings people together to help make a decision. But most of all, he puts patients and families first, and that's something that is really universally admired about Dr. Allsweet. So we're starting today with our topic about how do you get the conversation started? And I'd like to ask Dr. Allsweet to begin to educate us about advanced care planning. So Carl, this is a new topic for most people, advanced care planning. What types of problems are you addressing? For instance, when people typically, think about long-term care planning, they typically think of perhaps advanced directives. And maybe you could tell us about what is current state and what you are proposing as an alternative.
Currently, most people rely on either advanced directives or casual conversations with family members to talk about what their wishes would be if they were to have a severe medical crisis or medical condition and were unable to communicate their own feelings. What we see both locally in the mainline area as well as nationally is that most people's wishes are not well known, and if they are somewhat known, they are not respected. And in addition, the families are left to fend for themselves in a very trying time, in a crisis situation.
Mm-hmm. Now, when you say people's wishes are not respected, let's really start from the beginning. Do people really have a firm idea of what their wishes even are?
Most time they don't. What I'm saying is that that many people who state they would prefer to die at home if they have a medical condition, we know across the country that over 55% of those people actually die in a hospital, and so we know that on a research basis. But most people, because this is a topic that hasn't been needed in the past and is sort of shied away from as something very difficult to deal with, don't talk about it. So oftentimes wishes aren't known. These casual, I talked about casual conversations or advanced directives, and we know that only about 30% of people even have an advanced directive.
Mm-hmm. But aren't advanced directives really required when you go into a hospital? Don't you even have to fill out advanced directive paperwork?
No, not at all. It's not required, and usually the advanced directives that are available focus on such a narrow topic that in most clinical situations they're not applicable.
Why don't you tell our audience what you mean by a narrow topic or a narrow array of choices?
Most advanced directives that have been filled out by, like I said, the 30% of people who have filled them out focus on if they are in a terminal condition or in a permanent psychological impairment state. In modern medicine, a terminal condition or permanent psychological impairment is very hard to define, if not impossible to define. So in that sense, most advanced directives are not applicable.
Mm-hmm. Okay, so I think that people find advanced directives. Let's talk about the 30% that even find them. How do they usually even stumble over them? I know once I went on the web to look for advanced directives. Do people find them in different ways?
Yes. Some people find them as templates online that they can download and fill in themselves. Or many people, when they do their estate planning, go to a lawyer and get while they're filling out their wills, they'll also fill out an advanced directive at that time.
Mm-hmm. Okay. So you're saying that from your practice, you feel that this is inadequate, not only because only 30% even have advanced directives, but once they're in a clinical situation, there may be all kinds of different experiences where it's very hard to apply them to the clinical setting.
Correct. That is right. Most clinical situations don't apply, and then that leaves the families with a great deal of confusion and difficulty figuring out what to do for their loved one.
Mm-hmm. Well, let's step back. How did you get involved with this whole field? I mean, you were a surgeon, and then you decided to get into palliative care and end-of-life care. Was there any kind of event that occurred that sort of started to sway you in this new direction?
I've always been interested in sort of the transition between life-lengthening treatments and comfort and focusing on comfort care ever since I went through medical school. But practicing as a surgeon, particularly after cardiac surgery, I was involved with many of these situations where I really saw that the current state of planning for difficult medical conditions was just inadequate for the family and for the patients. I really felt and witnessed what I thought most people were getting was not what they wanted, and it also left the family without the proper support that they needed.
Mm-hmm. So you saw this as a major gap in care?
Correct. Yes, I did.
And how was it being filled through your program, for instance?
Well, my program is that I will fill in a lot of the gaps that are left with advanced directives in the sense that my focus is to find out and define at what level of disability the patient would find life acceptable. There seems to be, everybody has a point which says, I don't want to live if I'm living in a particular condition. And to me, that's what we need to document, that's what we need to find out. And then it's to plan medical care from that point on. And if they get to the point where they become disabled, then to offer advice and be there for counseling of the family members, and be a support to them.
Well, tell us about the advance in advanced care planning. When do people get involved with this planning process?
It depends on the people. Most people put it off until they're in a crisis situation. A third of my patients that I have are well into their medical condition before I get a phone call. There are other people who are much more diligent about planning ahead of this, and so it can be decades before they even have a medical condition that even becomes life-threatening or life-limiting.
Give us a couple examples of people that have been in your practice who really did think about this a lot sooner than when they were really in a hospital situation.
My very first patient was a young lady who is very professional, very skilled, very highly educated. But she's also single, and she knows that she is going to remain single. She's not going to have children, and she didn't want the burden of any of this decision making being placed on her parents and on her friends. What she did was she wanted to have these sorts of things straightened out before any crisis occurred. And in her case, her level of disability that she did not want to live beyond was she wanted to be able to knit in her own home and feed herself. If she was unable to do that, she wanted to be kept comfortable and allowed to die in a peaceful manner.
That's very interesting. So instead of saying, I don't want to be on a ventilator, or I don't want to be in a situation where I can no longer walk, she really saw it in terms of what she could do in her day-to-day functions.
And that gives clinicians a much better idea of what the patient's values are. Filling in a form and having a form it doesn't really give a clinician the specificity about that patient that they're taking care of.
So just walk us through the nuts and bolts in a case like that, or any case when people have really defined what it is functionally that they want to live with or not live without. How do you document it? How do you have the conversation? What really happens in this process?
Well, like I said, we define what values the patients they find important in their life. In the experience that I've had so far, living in their own home is a very important factor. Being able to feed themselves is an important factor. But probably the most important one, or the most common one, is the ability to have a meaningful conversation with their loved ones. Many of them feel as though it doesn't matter where they live. Once they get past that point, they would rather just be kept comfortable and allowed to pass away peacefully. So after we define that, and that takes a pretty long conversation. The initial consultations usually take about 2.5 hours. We write this up in an advance directive, or we give this to their lawyer and they write it up in an advance directive. But what I find is, I think the more important aspect of it is that their loved ones are involved with this conversation. And so even before it's written down on a piece of paper, the loved ones absolutely understand what the values are of the patient. And if they get to a point where they are approaching that, and there's any questions on that point, I'm available to either help them decide if they've reached that point, or whether or not, no, they haven't reached that point and we need to hang on with further medical treatments and such.
I wonder how families react to this. I'm sure that the reactions are all over the map. So give us a flavor of what those family conversations tend to be like.
Actually, I find the conversation to be very consistent.
Really?
I think that and which is in stark contrast to what I was seeing in a clinical situation as a surgeon. And
describe that to us.
When a patient is in a medical crisis and unable to communicate, and the families do not know what the patient's values are under those circumstances, the values and of the individual values of the family members comes to the forefront, and I saw a great deal of controversy and a great deal of fighting amongst family members about what is the proper path to follow from that point. Conversely, when I have these conversations and we really define what a patient wants, I've found that family members are more than happy to follow whatever it is, but they need to know specifically what those values and goals and wishes are.
That's a fascinating finding, really, when you think about it. So in the clinical situation where it is a crisis, you see all the family dynamics come out, and everyone has a different perspective of the same situation. But when it's not an emotional decision-making process, it's rational, it's thoughtful, then you see it is consistent that people really can come together and bond as a family and work that through very nicely.
Correct. And I think also because of the way I set up my practice, I am an employee of the patient, and the family members view me as a resource. It's a different dynamic than having to do it on their own. And they really feel, I feel many of my patients' families are more than happy to give up that control and that need for figuring out what the outcomes are going to be, and they're more than happy to welcome me in on that conversation.
That's very interesting. Now, you haven't been doing this where you would see, for instance, once they've made a decision and it has been written up, once they get into a crisis, people try to pull back on it, or they are consistent where they do follow through?
In general, yes. In the practice so far, people have been very consistent in what it is that they want and how it is that how they go about following medical care from that point forward.
Okay. So by extension, even though you may be focusing on one chronically ill person or someone that anticipates that this could be a problem either sooner or later, theoretically, this could be a family affair. Everyone in the family could actually go around the circle and have one of these consultations done and discussions done for their life experience, so that no matter when they would be facing it, they would really be armed with that knowledge.
That is my hope, and how I design this is that we have these as a family dynamic and a family groups and have a very long discussion, so that everybody in the family is aware of what everybody else in the family would like to do. Oftentimes, it is just one or two people who want to have the discussion, but I have done it where there are whole families doing all of this as a large group.
I see. Now, how extensive is this in the country? How many people are doing this kind of advanced care planning?
As far as I know, I'm the only physician who's doing it on a private basis as their specialty. There is one more practice in San Francisco that does advanced care planning. Otherwise, any advanced care planning that is done is usually done with hospital-based palliative care programs, and usually mostly for patients who are in the hospital. There are some programs that have outpatient palliative care programs. They're starting to crop up as palliative care becomes more commonplace.
I see. So the question is how to access these services, whether it would be for you doing it privately or for maybe a system to have different access points. How would people even know to raise it? If someone doesn't tell them about it, how would the average person know how to access such a service?
It's very, very difficult. Most family doctors can serve in this regard. The unfortunate thing about it is a very time-consuming, very labor-intensive practice from the physician standpoint. So many family practitioners are not going to be interested in doing it, but they have the capability of doing that. But otherwise, people are at this point not able to access it in too many ways. But if there is a local hospital that has a palliative care program, they may be able to call up and see if they have an outpatient program. If not, if they are hospitalized, a lot of hospitals are having palliative care programs or consult service, and they can ask to see those patients or see those professionals on the palliative care service.
I see. Okay. How are your peers responding to this? How do your other physician peers, for instance, see this kind of a service?
I think most of them are a little bewildered because of the newness of it. But once they see the power of it and they see that it's actually helping their patients, I find it very welcoming.
Very good. One of the things that you often hear is that sometimes physicians really feel like they are on the side of the team of really wanting the patient to live and really trying to pull out all stops to really help someone to live. How are they experiencing pulling back with having this kind of advanced care plan document in order to really think about their own practice and how much they're going to push the envelope, so to speak, in terms of medical care for an individual.
Here again, I think it's very similar to the family experience. I think most clinicians are more than happy to do whatever the patient wants. But without certainty, the clinicians, I find, to a high degree, are always going to want to push and go for as many life-lengthening, life-prolonging treatments as possible. But if they know, I find most clinicians are more than happy to keep the patient's wishes in mind and to comply with them.
Very good. How about when a patient has expired, died? Do you get any feedback from families in terms of how this helped them, or do people see this as having played a significant role in that person's care?
Yes, I've had a great deal of. It warms my heart to see what the families have gone through. The families have actually grown closer through this process because they are following. They're really focusing on the patient's, their loved one's desires, and really following through. So it's very gratifying for me to see that the families are actually doing very well and very happy with this process.
That's I think a very important aspect of this as well, because most people don't realize that it's not just the person who is experiencing a very chronic illness or an impending death. It's the grieving process of the family members that are left behind. And there are studies that I'm sure you could cite that have done research on the fact that people that do not have a lot of support during the actual experience of illness as family members often wind up with a lot of health problems themselves as a result of not only the caretaking, but just the whole grieving process. It sounds like this program really helps and supports the family members in their own experience of the parting of a loved one and their subsequent grief. Can you tell us a little bit more about that?
Yes, there was a report that was published in the Annals of Internal Medicine in 2010, which took a palliative care program that did advanced care planning and as an inpatient, and they offered it to some of some of their inpatients, and they compared that to the people who did not have the advanced care planning. And focused on the family's experience with when the loved one passed away, and it's either very good or very bad. It seems as though if the families do not have a crystal clear understanding about what the patient's values are, those family members wind up suffering a great deal. With post-traumatic stress, depression, anxiety that can be very long-lasting. This study went for 6 months, and it was a very prominent and very difficult condition for the family members of the person who has passed away. Conversely, if they knew what the values were, then the loved one's death was actually something that they felt very proud of, that they were supportive, and that they were honoring their loved one as they passed away. So it was it seems to be a new phenomenon that we're seeing with modern medicine, is that it can either be really very positive experience or it can be a very negative experience.
Right, and obviously part of your healing practice is to make it as positive as possible.
Correct.
Right.
Yes, that's true.
Now you've used that word values quite frequently. Do you have like a values checklist in terms of this process and evaluation, or do you just let people express their own set of values?
Yes, I generally find that people have their own values, regardless of religion, spiritual guidance, family members. It's very common to see long-time married people have very different ideas about what they want if they were to become ill. And so I think it's very important to find those individuals' values as far as what they would want if they were to become ill, disabled, and how they would want to go on living.
What's your prediction for the next 5 years in this whole regard? Do you think with healthcare reform, with more emphasis on being informed about healthcare issues and at the same time balancing it on the use of health resources, that there will be more emphasis on this kind of discussion in a different way, from more of a policy perspective, not just an individual trying to access such services?
I hope so. I hope that there is. Unfortunately, I am very concerned about if they're going to throw very small solutions at this problem, as opposed to a real robust program that actually helps people. I'm concerned that if physicians and people aren't trained to do this properly, that it might not improve the situation at all. So I know that I do know that there's a lot of the public that is very interested in making sure that this gets done properly, but I'm not sure that I've not seen, as far as policies being made, something that I would say, oh, this is going to work and this is going to help from a global standpoint.
So it's not necessarily getting the attention that it really deserves, in your estimation?
In my estimation, no, it's not.
Okay, well, let's turn the tables on you then. Say you were the policy czar in Washington, D.C. You're fully capable of being one. What would be your advice in terms of what kind of program, if you were in Washington and you were going to develop a program on a national scale, based on your rich experience of what you have done clinically? You understand, the needs of the community, and the communities are broadly defined, but this idea that you allow people to have their values expressed and then the care is delivered accordingly. What kind of program would you recommend?
Well, what I would recommend is that if somebody is practicing in the way that I am practicing, and this is something that they have a very high values, that they are board certified in palliative care, that they know the proper questions to ask, they can provide the proper support.
They're essentially credentialed to do that kind of work.
Credentialed to do this sort of work, that they would be paid by the patients in order to perform this work, and then the patients would receive a tax credit or some sort of incentive, some sort of financial incentive, in order to have this advanced care planning done. I firmly believe that this should not be paid by third parties because these are too important of decisions to be made to have a third party even have a conflict of interest in providing care after that point.
So for our audience, third party may not be a term that not everyone would understand. You're talking about insurance companies?
Insurance companies, Medicare. I think that if I was being paid by, currently I don't participate with insurance, I don't participate with Medicare, and that therefore I don't have to listen to them to tell me how to do this job the right way.
Right. So it's really a private discussion and a private payment system between the client, the family, and you.
Correct.
Not having the government structuring and setting up guidelines for how this would work, other than having the credentialed people to do it, nor would an insurance company, have a special interest in having people speed up the process.
Correct.
Okay. Well, thank you very much, Dr. Allsweet. This is a very provocative topic, and you can see that this kind of topic is one that is really hard to get that conversation going, but I think you've really helped us do that today. Thank you very much.
Oh, you're welcome. It's a pleasure being here.
Thank you.
Thanks a lot.
I hope you enjoyed our conversation today and that the information will help you in meeting your health goals. Catch this program and other conversations on the website, drnancyrn.com. Or you can write to me as well. I welcome your comments and feedback. Thank you for listening, and join us again. And remember, with health, all things are possible.